Assalamu alaikum everybody. We'll make a start now. So this first slide is a pun on me. आप इसको मोहब्बत मुल्क की भी कह सकते हैं, पेरेंट्स की कह सकते हैं कि this has brought me back to Pakistan. I've spent most of my career outside in England, and I've recently moved back to Pakistan. And we are aiming to develop this gastroenterology and hepatology service in Maruf, and inshallah we'll get your feedbacks and your criticism, I'm sure, as well as time goes on in developing this service. So let's start with our work. This is just a disclaimer that no characters are from real life. So for some people who are more interested in tabloid news from England, you might relate to some, but this is coincidental. So I'll start with a case. So I'm a Prince Charming in my 30s, about to marry a TV star, and I present to ER with hematemesis. Look pale, but not just married blues. I've not opened my bowels today, but I've been having some jitters in my legs and knee pains for which I've been taking some medication. So what we are trying to establish here, how do we proceed? So first of all, obviously the history goes on, and when I'm asked in ER, I admit to drink posh wine in moderation. My observations and initial blood chemistry is shows as follows. Hemoglobin is slightly low. I'm still on England money, so 105 in Pakistan's currency means 10.5 gram per deciliter. Urea units are slightly different as well, but this for England units is normal. But with the same blood chemistry, the point I just wanted to make was, if I just tinker with pulse and blood pressure, the things change dramatically in terms of how we manage and how we proceed with the patient. So as I'm in ER, my blood pressure drops to 90/60 and pulse goes up to 130. And this is not just the pretty nurses looking after me. The gist of today's presentation is more aimed on our junior colleagues, but I'm sure we'll find some good pearls of wisdom for my senior colleagues as well. So I'm going to touch on approach to upper GI bleeding with more context with gastroenterology. So first comes first. Patients comes first. So we need to establish what's happening, what's going on with the patient. Initial assessment should be ABCD approach, which is the ALS module on airway, breathing, circulation, and disability. Maintaining IV access. This is all initial management, and I'll show you a paper in as we go along and why this is important. Blood sampling, usual blood chemistry, including the group and save, because this should be done at onset. Catheterization, patient is, I would put it on second tier rather than the first, but this should certainly be considered in people who are going into shock. But there are more important things, but this should be in your to-do list. For our colleagues who are seeing the patient in ER, I think the ball should start rolling now in starting to plan what to do next and where do we go further. And this will help you in going which direction we are going for in patient management. When I was training, everybody said history is history and this has to be done again and again and again. With all my years of experience, I can tell you even now, and I'll share it with my junior colleagues as well, 90% of the patient you find out on history. If you pay more attention, you will find out what's happening. I think nowadays we are more inclined on using the investigations as our tool, but still history gives you a lot of clues in where you go next. So aims of the history should be identifying the likely source and a potential cause, determination of severity of bleeding, and obviously identifying the precipitants, because this would help you in planning how quickly we need to intervene. So in terms of history, I'm not going to go in details. This will be like teaching babies how to suck candy, but just few pointers with regards to GI bleeding. Duration, frequency, and volume of bleeding can indicate the severity of bleeding. Nature of bleeding, nothing in medicine in black and white, but in people who are having hematemesis or melena, it would suggest more upper GI bleeding. Dark red blood suggests more coming from colon, and bright red is the distal part, which is rectum and anus. But this all changes if patient is clinically very unwell, because something which we called is fast transit. In that way, which means if you're having a fresh melena with fresh red blood and the patient is decompensating, then this might be coming from the upper GI tract. So this is why I don't want to just ask people to focus on this is what we are talking about, but just have it in the back of your mind. Associated symptoms can guide you in deciding which investigation is of choice in the first instance, because we all know from experience in ER, deciding on which way we go in the first instance determines the outcome of the patient. Like an upper GI bleeding or dyspeptic symptoms in the past could or abdominal pain would suggest more peptic ulcer disease. Change in bowel habits can point towards more sinister lesions, and then you can decide on whether endoscopy is the next port of call or a CT scan is the first choice. Past medical history, sometimes we overlook, but it's important, especially for me when I'm planning for my next steps, like previous bleeds, assessment of chronic liver disease, previous ulcers, bleeding disorders, etc. And nowadays, people are of the age of polypharmacy, antiplatelets and anticoagulation come in different forms, sizes, and brand names. It would be a good an important task to just have a look, because this might be important in immediate management of the patient. I feel no shame in admitting that a lot of time, because there are so many brands, I just check on BNF or Pharmapedias or any of these portals just to check what exactly is in the drugs patients are taking. Examination wise, now examination. I would stress this a lot. Although upper GI bleeding, it might not be of paramount interest, but this is an important tool in assessing how quickly and how promptly we need to assess and intervene with this patient. So as the actress in the picture, Hema Malini, is saying, whenever jab dharkane or bechani badh jaye, this is your first clue that something else is going to happen. So assessment for conscious level, clamminess, tachycardia, thready pulse, etc. As I said, we all know all of this, but rehashing and practicing makes it our second nature, which should be. I would here stress the importance of digital rectal examination, or PR as we call it. A lot of people, melena means a lot of different things, and black stool means a lot of different things. Black for me in terms of gastroenterology is only one color. It used to be the color of my hair, which I have now lost, but black is only one color. If you're confused between shades of brown, then it is not melena. Melena will never lie. And to be honest, when I was training, people used to say, if somebody has melena, even the next door neighbor would know it's melena. This is how pungent it would smell. This is something I just wanted to bring up. Nowadays, we are in age of lots of screening tools and scores. This is something which has been validated, and I will show you the validation paper in a minute. But I think in our practice, if we start using it, this is a heavy slide. You don't have to memorize all of this. Just the parameters that we consider are urea, hemoglobin, blood pressures, and some of the other parameters. It's readily available on lots of scoring apps and mobile websites. So don't stress yourself in memorizing, but it is called a Glasgow-Blatchford score for GI bleeding. One thing I would like to emphasize is these scores are very good in what we are doing for assessing patients, but they are important to be taken in context. A lot of people now, if I could tell you now, if a patient who's on dialysis and chronic renal failure, you start doing this score, it will be high. It will not tell you that patient is bleeding or not. It will tell you the intensity or need for intervention. So you need to establish first, is the question or medical question, is GI bleeding? If the answer is yes, then these scores will help you in assessing which way we're going. So Glasgow-Blatchford score is used for assessment of how soon we need to intervene, whether this patient needs inpatient management or outpatient. A score of 6 or more requires the urgent assessment and intervention. A score of 0 to 2 means we can assess and manage patients on an outpatient basis, especially when the beds are at premium. But at the end of the day, it's the doctor's gut feel and what is in front of him that should determine which way we're going rather than the scores. Another risk stratifying score is a Rockall score. It identifies the long-term outcome following an upper GI bleeding. We used to use this score a lot before, but nowadays it is more important after you've done the upper GI endoscopy rather than before. Again, I don't expect and I don't want you to trouble yourself with memorizing all of this. These are all available. In terms of validation, this is something that was published in European Journal of Gastroenterology, and it was used for validation of Glasgow-Blatchford score, and the results were the same. For a score 0 to 2, outpatient management can be considered. Above that, inpatient management, and depending on how high the score is, we should consider the timing of intervention. Just a bit of, before we get into details of what's going to happen next, just I want you to familiarize with the causes of upper GI bleeding. Common things are common in medicine. Peptic ulcer disease, gastric erosion, and you can see esophagitis are by far the leading causes. We see, and especially people who've got interest in hepatology and pancreatology like me, you tell me the patient has got chronic liver disease, we start getting excited about varices and portal hypertension, but you can still see from the data that even in that cohort, chances of upper GI bleeding or etiology is more ulcer and inflammation rather than the varices. But regardless, we should not ignore what we have in front of us and try and treat the patient as it is deemed fit. Right, just a thought on what we're going to do next. Gone are the days when we used to have a face-to-face presentations and all, and I would pick on somebody who was either sleeping or not listening to me, but now I feel like I'm talking to myself, so I'll just carry on and move on and answer these questions by myself. Right. Let's say let's touch on two major sources of bleeding. One is the non-variceal bleeding and one is the variceal bleeding. As I listed on the last slide, we still we would manage patients as what is in front of us, but I'm going to divide the stems on non-variceal and variceal bleeding for treatment sake and for the initial management of patients. So for emergency management means whatever we are doing when the patient steps in our door. This is of paramount. This is what we discussed before: getting 2 IV lines, getting fluids, getting blood tests, supporting the patients. Everything else will follow. But the initial management is the most important management. And lots of research and lots of paper would elicit that it is not the endoscopy, it is not the surgeries, it is not the CT scans or the initial investigation that saves the patients. It is what is done on the front door. And I'll just bring your attention to this paper that was published in Gut. And this is one of many. The timing, the importance of this publication was to establish what is the timing of endoscopy for upper GI bleeding. But you can, I can share this for people who want to know about and read about it a bit more. But if you read through the data, you would see it is not the endoscopy or the timing of the endoscopy that determines the outcome. It is how the patient is managed within the first 4 hours for the emergency management, the supportive care that is given to the patient, and the mortality outcomes are different on the basis of the first presentation. When we see upper GI bleeding, I accept that it is very difficult for patients, let alone doctors, to leave and just shy away from blood, because blood on the outside is not natural, and our first response would be, I have to do something in terms of intervention. But let me assure you, with all my experience and all of this data, that whatever you do for the supportive management in the initial few hours determines the outcome of the patient, regardless of when we do the endoscopy or the surgery for that matter as well. Coming back to that, now my bread and butter, which is in medical fraternity terms, everybody comes with his hammer, and my hammer is endoscopy. So whenever you tell me there's GI bleeding, I would say, yeah, ting, 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 this is time for endoscopy. I'll just show some gruesome pictures. I'm sure as time progresses, I'll be showing you some videos from what we are trying to establish here. This picture techniques is application of hemoclips. You can see the black bit right on the top right of your screen is the camera. This is a close view of the fundus. Because the camera is looking back on itself, that's why you see the shaft of the camera. And what the operator is trying to do is close the gap with a hemoclip. The next technique is this, which is APC. This is argon therapy. The lesion in question is Delofoy, which is basically an aberrant vessel that is bleeding, and we are burning it. These are amazingly difficult to find, because once they bleed, by the time of intervention, a lot of the time we can't find it. So the timing is very important in these as well. Angiodysplasias are treated in the same way. This technique is heater probe, or some technology would call it gold probe technique as well. This is basically thermocoagulation. In an ulcer, sometimes it is not feasible to put clips on, and what we do is in all quadrants around the ulcer, because the bleeding vessels in itself, and you can see through the picture as well, I'll point towards this side. The bleeding artery that we see in the middle of the ulcer crater is not the end artery. It's usually a pseudoaneurysm that is formed, and that bleeds. And what we try to do is we try to photocoagulate around the ulcer in the first instance to thermocoagulate the arterioles or capillaries around it to stop the bleeding. More importantly, again, is the establishment of what we do after once we've done the endoscopy. And the data shows reducing pH less than or more than 6 rather stabilizes the clot and stabilizes whatever we've done during the endoscopy or therapeutic endoscopy, which means giving IV PPI infusions. This is my job to put it in the report for what rate and what quantity I want this, but this should be carried on for at least 72 hours. Because this stabilizes the clot and reduces the risk of further bleeding. Tranexamic acid historically was used with variable benefits. Studies more need to be taken up. I think post-procedure, the role is not very promising, but pre-procedure, especially in centers where endoscopy will take a little bit of time in establishing, it is not going to hurt giving tranexamic acid. If H. pylori eradication is indicated during the tests, then that also reduces the further bleeds. I must admit that during our therapeutic endoscopies, I generally would not test for H. pylori through the endoscopy, as my sole interest is stopping the bleeding. But for gastric ulcers, usually I would advise on empirically treating. But as I said, this is an endoscopist and a gastroenterologist's job to guide and to make a plan. Stopping aspirin, clopidogrel, warfarin, or any non-steroidals depends on what is the clinical benefit and outcome. I'm not going to give you a blanket advice on anticoagulation, because there are lots of different indications now people have it, but certainly depending on the indication, we should start thinking about at least withholding them. Apart from metallic valvular heart disease and a recent thromboembolic episodes, I would have a very low threshold of stopping anticoagulation and the antiplatelet therapy, at least for a little while. This is certainly a consultation that we can have with cardiologists and stroke physicians, depending on what the need of the medication was. So this is, we discussed this. So this is something I wanted to, a lot of people would think how much to anticoagulate, how much to transfuse blood. It was always our first instance, and in ER and the medical specialist, the first instance is let's get some blood in the patient. This is a paper that was published in a New England Journal of Medicine. It took a lot of hype. It's been validated as well. And the strategies of this paper was to compare between a restrictive transfusion regime and one with giving liberal blood products. This is a meta-analysis as well, and you can see in the restrictive strategy, which means keeping the hemoglobin levels between 7 and 8, had significantly better overall survival outcome than liberal strategy. And this is the recommendations from the British Society of Gastroenterology and all the societies. They've got a consensus that for upper GI bleeding, the optimum range to maintain the hemoglobin should be 7 and 8. But this comes with a caveat that people with frailties, patients with ischemic heart disease or other comorbidities, you need to reestablish again, and probably keeping hemoglobin above 8, I would recommend. But the important thing, take-home message from this slide and this study is that we should not aim to over-transfuse patients, as this negatively affects the outcome of long-term survival. Because a healthy body would regenerate. You need only, obviously, if patient is having symptoms of anemia like shortness of breath, cardiac sounding chest pains, or blood not maintaining the blood pressure exactly, then that takes precedence. But this is more for patients who are asymptomatic. So please do not try to bring up the hemoglobin to their normal limit. Body will try to compensate in its own time. Just a gruesome picture to gross people who are not involved with gastroenterology. This is a forest classification, and you would see this a lot in gastroenterology reports and endoscopy reports. We like to grade them. This is more for benefit of whatever we want to do next with them. So this is called forest classification, and it is widely accepted. The reason I wanted you to familiarize with yourself is this, because the risk of rebleeding, if no intervention is done, is higher in forest 1A and 1B, and it progressively decreases after that. So for my sake, if I see an ulcer and I see a clot or a vessel or a recent ooze, I would much rather be inclined in treating it in the first instance, because the risk of rebleeding and risk of mortality is very high in these patients. For medical knowledge and for inpatient teams, it is important to plan on discharges as well, because the guidelines are for gastric ulcers, you should have a repeat endoscopy in 8 to 10 weeks to check for ulcer healing. Because these ulcers, yes, on the first instance, might not appear to be sinister, and because the more strategy and more focus is on stopping them bleeding, it is important and imperative that we have another look when everything is settled to check and confirm ulcer healing. If there is no or delayed ulcer healing, then further biopsies need to be taken. Further management plans would include vascular intervention and obviously surgery. This all depends on what we can and what we can't offer endoscopically, because endoscopically, if there are big ulcers, a lot of these, and I've come across them as well, even if they are not bleeding, they are massive, and it gives me nightmares to touch them. So my inclination, and always, and I keep telling myself during every intervention, is less is more. So don't try to fix something that ain't broken. And it gives me no shame in asking the surgical colleagues or the interventional radiologists to get an early input if there is nothing that I can do endoscopically, even in the current setting or in future. Other novel techniques that people use, and it is of a bit questionable, let's say, effectivity, is capsule endoscopy and RBC labeled scans. These are good ideas and good things for research centers and people who are interested in them. But I think for our community basis, the outcomes and use of them is fairly limited. The nightmare for any gastroenterology and hepatologists, and I must admit for ER physicians and interventionists as well, is variceal bleeding. It is important to assess the patient for signs of chronic liver disease, because once they start bleeding, they give you nightmares. They would hose buckets and buckets of blood, because these are all portosystemic shunt bleedings. They profusely bleed, and the patient can decompensate very quickly. So initial management with terlipressin, antibiotics, and vitamin K. Vitamin K is not to reverse the PT, it is more, or prothrombin time, it is more important for replenishing any deficiency that the liver might have because of the synthetic damage. So my practice usually would be giving 20 milligrams stat IV, and then you're done with it. You don't have to worry about replenishing the nutritional side of things. Antibiotics is paramount in starting. I would start on piperacillin tazobactam. The importance of this is because this is a negative flow bleeding, because this is more from the venous system. There is a high chance and high risk of bacterial translocation from the gut into the bloodstream, and in the majority of the cases, mortality is more because of the bacterial transformation and translocation rather, and sepsis rather than the bleeding in its first instance. Again, I would stress that we do not need to bring the blood pressure very high up. 100 systolic is probably optimum. I would recommend keeping the hemoglobin around 70 and 80 grams, but in Pakistan money, it would be 7 to 8. Don't over transfuse. Don't give colloids for bringing the blood pressure up. If we need to, probably blood is more better, and normal saline or Hartmann or Ringer's would be better, because you don't want to bring up the internal postosystemic blood pressure up, because this will increase the chances of bleeding and increase the flow of bleeding. Something to, if you want to score brownie points, is to establish the cause of decompensation. People do not bleed from varices just because they have varices. There is a bottom line, there is a reason, there is always a trigger. The triggers generally are infection, which can be spontaneous bacterial peritonitis, or they have done something different. In our context, it is usually a herbal medication that they've started to take, which can tip the balance and start bleeding. When I see the patient after we've done the initial assessment, and initial therapy would be to make sure they don't have portal clots, because if they've got portal thromboembolism, then you can imagine treating with anticoagulation would be a real struggle in somebody who's just bled. Therapeutics again would include management for esophageal and gastric varices. I will show you some gruesome pictures. Gastric varices are usually our nemesis, which are hard to treat and hard to plan for next steps. Radiological intervention usually is tips or putting other shunts, which are more site driven as well. The long term and the biggest management, or the, let's say, assessment should be done for transplants for candidates who are suitable. Of course, it is important, again, as I write in my last line, to plan for rebleed. What happens if he rebleeds? If the patient rebleeds, then there should be a plan in place already, because it's not, they don't usually give you a lot of time to plan once they start decompensating. This is a nice juicy esophageal varix that you can see at 11 o'clock position. This is grade 3. You can see more 3 columns at 1 o'clock, 5 o'clock, and 7 o'clock position. And if you just have, for all those who've got eagle eyes, you can see there's where I'm pointing my mouse pointer, there is a punctum or a red spot. This is where the patient has bled. There's something here as well, more distally at the geojunction. We go in with the bander. This is the transparent stuff is the cap. You can see the black circle line. This is esophageal band, and this is a band that is applied. Another screenshot of further esophageal banding, and you can see that this proximal to the band, if you compare it, this column has decompressed. So the idea is that we band it around the bleeding point so that the rest of the column is decompressed. It is as simple as you might be thinking. This is like putting a band around a balloon and stopping the air from flowing out. This is a technique that we do have in Maruf, and as the time would go on, we have already had a look at our service. Inshallah, most of these interventions we will be offering to our patient cohorts. So our colleagues who are looking after these patients can plan this, discuss with me or the team, and we can have this service going on. I know the management and Wahid Saab and Haroon Saab are very passionate about developing our service in endoscopy, and inshallah we've already made a lot of strides in developing the service. A lot of these things are already in our stock, and we can provide our patient cohort with initial managements and long-term managements, inshallah. Our project at Maruf vis-a-vis endoscopy is to develop a center of excellence for endoscopy, so we don't have to transfer our patients across to different hospitals, to provide prompt and timely facilities to our community, and obviously to educate our colleagues and educate our patients as well, that this is something that we do offer to our cohort and our community of patients, so they know they don't have to travel far and wide to get this service. For the eagle eyes, who I'm not going to say for, and I think I can see that there are some younger people. So my slides previously were from this old time movie, because I've got an old bone in me, as my wife says. I've got my grandma's spirit in me. So yes, I'm sure there are more chic and more up-to-date references, but I'll stick to what I know best. Any comments and questions are welcome now. Thank you very much. I think I've bored you to that.
Thank you very much, Usman. Can you hear me?
I can hear you, yes.
Yeah. Usman, thank you very much. It's a detailed presentation of a very important topic, which I must say we see in a relative low acuity than what we are used to seeing in the Western world. We do have a few cases here where actually we lost one young female with GI bleed, and the problem was that I, being the emergency physician, was pushing for an emergency or an urgent endoscopy, whereas our GI colleagues were not very happy in doing that, and eventually we were not able to do anything about her. So I think you've given us a very clear idea of the message that initial resuscitation and then endoscopy within 24 hours. So that's, I think the clarity is very important, and this should be, I think, conveyed across all the practicing gastroenterologists within the MIH. The other thing is that I would like to take this opportunity to welcome you to Maruf. And we really believe that this is a specialty which has a lot to offer in terms of patient satisfaction and good outcomes within our community. And myself and our CEO and the whole team is really excited to embark on this project. And as you can see that we have already asked for new equipment and all those things which you need to inshallah establish a service which would not require any of our patients to be transferred somewhere else. So thank you very much, and I welcome you to Maruf.
Thank you very much. Pleasure to be here. So thank you very much. If we don't have any questions, I think Rabia and Zohaib, are we happy to close the session?
Yes, sir. We can close the session.
Yeah, thank you very much for all who have joined. I'm sure we will try and pick up more topics for our mutual interest in future.